Welcome to Wednesday Skincare Live, and today it's all about pigmentation. Our guest today is Dr. Justine Hextall, phenomenal dermatologist who's been on here a little bit advising us on different things, and today we're going to talk about how you identify different types of pigmentation, what kind of treatments in clinic you can do, which treatments you're going to maybe put a kibosh on and say they don't work, because we like to say what's great and what's shit here, what at-home treatments you can do, Trinny London obviously, and also what are the kind of, if you are worried that you have some kind of skin cancer, how can you at home do an element of diagnosis, and at what stage do you need to make sure that you get it checked out so that a professional like Justine, Dr. Justine, can do that for you and put your mind at rest or tell you what to do. And I think that we've come back from the summer. Those of you who are from Australia probably have a far better education on pigmentation and on skin cancer and looking and identifying what they are in the way that in England we do breast screening. I think it's a real given. So those of you watching from Australia, you know that you have the sun all the time. So how can we prevent pigmentation? When does it arise? We're going to talk a little bit too about hormones and how that can kind of push those little melanocytes through that cause the pigmentation, and at what stages in our life they appear. And when something goes from a baby to a big one, what's happening to that too, just like behind the scenes. So to say good morning to a few people. Michelle, good morning. Manny, good morning. Lucy, good morning from France. Michelle's in Sydney. We have the pop-up in Australia we're coming to, very excited, leaving for Sydney on the 18th of September. Wendy, good morning from Yorkshire. Jane Goodall, good morning, Jane. How are you? Hope you're well. Noah, good morning. Eniko, good morning from New Zealand. Sigrid, it gets hotter and hotter, so we've chosen. Annette, good morning. So let's start with how we identify what is pigmentation on our face, and take it from there.
Okay, so pigmentation is, well, I guess we're talking about unwanted pigmentation because our skin pigments to protect against UV. So this summer, most of us, I imagine, are probably got a darker skin tone because we've had so much sunshine. But I think that the problem comes when we have what we call unwanted pigmentation. So that might be, for example, sunspots. So if the melanocytes constantly get damaged by UV, eventually you start to get what we call sunspots or sun damage, or we call in dermatology terms solar lentigines, and so you get these little brown marks on the skin, and that affects all skin tones.
And what age as well? Because like my daughter Lila, who's slightly more olive, and I always think it's slightly less with olive, but maybe it's not showing so much, but she won't get them now. She hasn't got them now. She goes in the sun, she does wear SPF, but she's, you know,
her time will come.
Her time will come. But what is that time? Is it different for different skin types?
Different for different skin types, different to how you react to the sun as well. So some people don't cope with light as much as others. But I mean, those with darker skin tones, it's one of the most common signs of aging is that dyspigmentation. Where someone like me, who's very fair, probably more lines, more fine lines, so it can be a marker of what we call photo-aging. So it does depend on the skin pigmentation, the skin type, how much sun exposure you've had, etc., etc. I mean, I've got some patients who say, I really burnt the side of my face, and you can tell the difference, even just a couple of episodes, you know, of it later on. But it tends to show later on, so you won't see it necessarily in your 20s. We can show it with we have a machine in the clinic where we use a busy machine. We can show UV damage, but you may not see it early on. But round about the time, sort of probably 30s, 40s, people start to notice it. But we do notice it much more, quite often around the time of menopause.
I mean, there's a lot of work now on UVA and UVB rays and the difference. Claire, who's our Chief Innovation Officer, who you've met, we always say UVA is aging, UVB is burning, in terms of a very easy way to understand. Which one causes pigmentation more?
I suspect it's more, well, both will cause pigmentation, but as you say, UVB is a shorter wavelength, it's high energy, it's one that when we talk about SPF, we are referring to protection against UVB more. That's what we're measuring, protection more against UVB. So that's dangerous, high energy, and it will cause damage direct to our DNA. But UVA, as you point out, goes much deeper into the skin, where the collagen, all the areas are, you know, where we're trying to hold our structure together. But also UVA, or longer waves undertones, UVA, can be involved in pigmentation for sure. And I think one of the things we have to worry about is sun protection can traditionally protect against UVB, UVA, but those longer wavelengths, which are more difficult to protect against, and even visible light, seems to have a role in unwanted pigmentation.
Because, Leanne, let's talk too, because when you think of burning rays, you think I'm on a sun lounger burning.
Yes.
But I think it's really important to understand, especially as you get towards menopause, how when it's cloudy in the sky, that makes no difference. And you will literally think, if you don't wear SPF, it's going to, how much damage it's going to cause. I don't want to be fear-mongering, but it's like really understanding when you're getting the damage.
I agree. And, you know, we, as dermatologists, we will say about 80% of what we consider to be, and skin aging and photo damage comes from external aggressors like UV and also pigmentation. And interesting, there's some evidence that longer wavelengths of UVA in combination with pollution can work, we call synergistically, and cause more damage. So if you're in a city and you're getting UV, you want to really protect against those longer wavelengths, particularly having pollution as well. So it is difficult to protect against that longer those longer wavelengths, and things like antioxidants can help in that sort of area.
I mean, I think that, you know, we do talk a lot at Trinny London about this kind of history of age groups and what you should do. So in your 20s, if you join us and you do, but to do vitamin C before your SPF, which we have a 30%, but just it's about, it's going to, we always say it takes the hit a bit.
Yes,
you know,
it does.
so it just softens the blow. And if you haven't done that in your 20s, they do kind of come back perimenopausally. I think in hormone, let's just talk about that hormone fluctuation of body and when it appears, because a lot of people watching might have just had a baby, they might be perimenopausal, and they suddenly get them. So it depends on what's happening inside our body.
Basically. So we know that estrogen, progesterone in combination with UV can cause what we call melasma. So it's often a symmetrical pigmentation, often sort of here, sort of forehead area. It can be above the lip, and people don't like that because it looks like they've got sort of hair there. And that's common, and triggers for that are pregnancy, perimenopause, you start to get sort of estrogen peaks, etc. And things like HRT, obviously you're taking sort of hormones, or even using them topically, you can get pigmentation as well. So it's that combination of hormones and UV which seem to create this melasma. But there's lots of interest now in things like inflammation and skin barrier function, and there even may be vascular involvement in melasma as well. So it's not just, you know, it's a bit more complicated. And the problem is that once it's triggered, it's sort of there. You've got your melanosomes, which are what hold your melanin, your pigment, and they start to move up towards the keratinocytes, the top of the skin, and it's about trying to block both that pathway and the production of melanin. And so, if you want to treat melasma, we can treat
in clinic. How do you treat? So let's just start with a single age spot.
Okay.
How do you treat it to melasma, which is a cluster and hormonally triggered?
Okay, okay. So a single age spot is probably a solar lentigo, so it's probably a sunspot. So as a dermatologist, it's really important to make sure that is just a benign sunspot.
Yes.
And I worry about people lasering things, they don't know what they're lasering.
So you need to see a dermatologist
well,
to do
in my view, you need to be careful, you know. So for example, if that spot has got bigger, it's become irregular. It used to have a smooth edge, now it's got a raggedy edge. Say, for example, it's got very good pigmentation, so it was usually light brown, now it's got darker areas or pinker areas within it. That's a flag, you know, that's a sort of worry. And you really want to make sure someone gets a dermatoscope out and looks at that very carefully to make sure.
Dermatoscope being something that you see microscopically.
Yeah, that's right. So you can look, and we recognise certain patterns we look for as a dermatologist to tell us if we're concerned. And even with a dermatoscope, you can't be always sure, and I would say be cautious, take a biopsy. And even a biopsy is only a sample of that area, so that's, you know, but on the whole, make sure you're happy, it's entirely benign, it's just a sunspot, and if you are, then there are ways of treating that. And, you know, a classic area way of treating that might be, for example, things like laser. You might use, say, some intense pulse light or photofractional, where you combine intense pulse light and fractional. You might look at things like Q-switch laser. So there are different lasers that you can use to treat.
I mean, would you ever do, because I do for little dark spots, I do freeze it?
Yes, again, so I would tend to use freezing for things like what we call seborrheic keratoses, and these are sort of an overgrowth of the top layer of the skin, and they're quite common, and again, dermatoscopically we can tell what they are, but I will tend to use cryotherapy on those sort of lesions.
But not on pigmentation?
No, because if you're taking that pigmentation out, you can with cryotherapy. This is just my view. If you're freezing that and removing that pigmentation, one of our hints that a solar lentigo is changing is you can get a change of pigmentation, and you're reducing that ability to spot that early change. Yeah. So you have to be super cautious when treating, solar lentigines or sunspots. You've got to be careful, and I'm always quite cautious.
Okay. So if you are looking at laser and you do laser treatment, do you believe that if you go on a laser journey, then you're more sensitive and you have to be extra careful with SPF?
Yes, so particularly in patients who've got a sort of darker skin tone, you have to be very careful because heat, any device that's going to create heat can cause, for example, inflammation and further pigmentation. Yeah. So if you're tackling something like melasma, the first step is to try and suppress it and suppress the process. So I would go in with any treatment, any peel or any laser, until I feel I've really suppressed that process. Particularly,
how are you going to suppress the process?
So you're going to suppress the process in different ways. So for example, you might use a prescription treatment. So you might use, for example, hydroquinone. We do still use hydroquinone.
You still use it in clinic because it's a very old-fashioned treatment.
It is an old-fashioned treatment,
but with
caution. And so you may use, for example, hydroquinone in combination with things like a retinoid and also a weak anti-inflammatory. That combination can work. You might use things like tranexamic acid. That's quite new, and studies have shown that oral tranexamic acid can suppress the pigmentation process. And there are some studies suggesting that topical tranexamic acid can help as well. So we do look at those sort of treatments, and then you say retinoids. You might use very light peeling, so you might use something like an AHA or PHA vitamin C as an antioxidant. You made that point earlier. If you're going to use a high fat sun cream, put some vitamin C on as well, because if that light comes through, at least you're mitigating it. It's that free radical damage, and that's what causes your pigmentation. That's what causes your damage. So if a double layer approach basically. So you really want to make sure that you're suppressing the process. That person's got a really good day in, day out skincare regime, which they're going to be using onwards basically, and then you consider what treatments you might use, and you are super cautious because you do want, in medicine it's do no harm, so you do not want to cause further pigmentation, and that's always a risk.
Okay, we're going to take a few questions from the floor. I'm going to start with one. What can you use on your face if you have a basal carcinoma and have had cryotherapy? So basal carcinoma, for the other people watching, is what?
So basal cell carcinoma is a very superficial form of skin cancer, and it's got there's 3 different types. The most worrying type is what we call an infiltrative basal cell carcinoma, because that can infiltrate around things like the nose or important structures. So in that situation, you absolutely want to get good surgical margins. You want to cut that out. Sometimes if it's a superficial form of basal cell carcinoma, people may take a more topical approach. So for example, things like you might do that, or topical and chemotherapy treatments, or when things got what we call photodynamic therapies. There are different approaches in that situation. But so it depends on the type, where it is, the age of the patient, etc. But in an ideal world, you want to make sure this is treated.
All right. I need a cheek colour, she's saying yes. Okay, thank you. How would you treat melasma? So if you're just joining us, Sarah, I think we're looking at the different lasers that you mentioned.
Well,
so tell me sort of step 1, 2, and 3. Like, I'm going to ask you, if I would say there's short-term, medium-term, and long-term.
Yes.
All right, in terms of some people might not have access to a clinic. So, like short-term,
you've got to protect. That's the first thing I would say.
So high SPF.
High SPF. Ideally, if you can, so for example, if you don't have to be on the, say, contraceptive pill, and that seems to be your trigger, then you might want to consider sort of a different form of contraception. If you're constantly, if the pill has triggered it, then I know that's not an easy answer, but it's often that combination of hormones and light. But you need to protect yourself against the light. So that's going to be using really good high factor broad spectrum sun creams. Some people believe that using a physical block, so your zinc oxides, your titanium dioxides, your iron oxides, gives you a bit more of a broad spectrum cover in melasma.
I think there's so many out there now that, and we did a thing of 40 sun creams. So we went through, if you want to understand really good ones, and we broke them down between mineral and sort of blockers and non-blockers. then just look at the one we did, I think 2 weeks ago on this channel, or 3 weeks ago on this channel. So SPF is that prevention. You've already got it. So we talked about using retinoids, vitamin C's and acids to kind of reduce it a bit. But when they get to a certain size, so when you get those kind of big ones, or you have melasma, which is that block, then what are you looking at? So
sure. So and just to touch back on the skincare again. So using things like retinoids and acid are great, but if you overuse them and you're causing inflammation, you might drive the process. So it's really important to balance treatment, active treatment, with balancing the skin barrier. Because there's evidence now that, an ineffective skin barrier and inflammation are also contributing towards melasma. So it is that tightrope of making sure you're being active, turning the skin cells over, but also not creating too much inflammation. Making sure that you're protected as much as you can. So, for example, your vitamin C, which will work as an antioxidant, but also will help in the pathway production of melanin, and then your really good high-factor broad-spectrum sun creams. And then looking for other ingredients. So, for example, niacinamide helps to stop the pigmentation going towards the skin. It's also anti-inflammatory, helps the skin barrier. Azelaic acid, things like kojic acid, licorice.
Yeah, can we just talk about kojic? Because kojic to me is on the fence, because some people, I have a dermatologist in America, Julia Hunter, who's a fantastic dermatologist actually, but her worry of kojic, and this just is that it's quite an aggressive topical treatment, and then you stop using it, and it can come back with a vengeance. So
I think anything that's aggressive topically, you're absolutely right, and I agree with that, etc. You have to be careful about sort of inflammation and creating inflammation, and that in itself can contribute. So I agree with that. I tend to use things like topical tranexamic acid. I will use
these are prescription.
But yes, but you can get quite high percentages now of tranexamic acid. In over-the-counter treatments as well, azelaic acid. All of those things. So we've done all those things. So we've got the skincare in place, and then we might use prescription type treatments. So that's things like your retinoic acid. You might be using I will use some hydroquinone, but very carefully. You do not want to have, if you're using hydroquinone, it has to be carefully monitored by a physician. Do not try and buy because I've seen problems with that, and you want to use it for a short period, so you have a prescribed period. But things like topical tranexamic acid as well. So I use something called Perfect Bleaching Cream, which I quite like. It has different things in it to help suppress the pigmentation.
Can I ask you, tranexamic acid, people are asking percentages, what is the best percentage?
Well, so you're looking back sort of 5%, about 5%. And then you can obviously give oral tranexamic acid. Again, that's prescribed, and there is evidence for oral tranexamic acid. And people do prescribe that.
Christelle, my melasma spot, as big as my pinky, is barely noticeable after 3 months during London skincare. Oh, okay, thank you. Very nice.
Brilliant.
Very nice. Carrie Ann, look into Skin Lupisar and Beauty Focus Collagen Plus. I can help if you want to purchase. That sounds like, okay. All right, questions. Faith.
Okay, it sounds like a lot of the treatments you've mentioned could maybe be quite harsh on the skin. Can you still treat pigmentation if you have sensitive skin?
Yes,
that's a very good point.
Very good point. And it's really important that you don't trigger inflammation, and that you try and keep the skin barrier intact. I absolutely agree with that. And so if you've got a sensitive skin, I would argue with all actives, introduce everything slowly, and make sure that if you're using an active, you're also balancing that with really lovely, hydrating, calming, nourishing skincare.
Like comfort cream.
Comfort cream. So you're looking for a gentle cleanser. You're looking for lovely, sort of ingredients like things like shea butter, glycerin, hyaluronic acid, all those things which draw moisture to the skin and help to protect and maintain.
Lubricate whatever you're putting into.
Absolutely. So you want to balance the skin barrier, keep that intact, because that could contribute towards a problem, but also to gently treat the treatment and build it up. Our skin will get used to treatments, but you have to build it up and be careful. I think one of the most common problems I see in my clinic is people going, right, I'm going to go for it. And as I always say, one chocolate, is great, but 4 can make you feel a bit sick. Same for your skin.
Okay. I only interrupt, Justine, when I see there's a lot of questions, and I feel people watching would like them answered. That's also we're in a subject. That's why I know somebody saying you keep interrupting, but I try and do it to get the questions in.
Okay, you mentioned the contraceptive pill earlier. I'm just wondering, how does that play?
Because and also you mentioned HRT, because it's a really tough one. Those two things are things people take medically for a reason.
Yes,
but they are estrogen boosters, as it were, and that's what's going to create that hormone change that will lead to pigmentation. So, I mean, Yeah, how can you do it where you're not feeling you're changing your prescription? Is it just about trying different pills, and some have different estrogen levels?
I think that, you know, for example, I agree, if you're really benefiting from your HRT or your contraceptive pills working really well for you, then you're just going to have to think to yourself, okay, you know, then what I've got to do then is block the other pathway, which is a UV pathway.
Mm-hmm.
So if I'm going to stay on this and I want to do this, and interesting in HRT, people often get what we call extrafacial melasma, so things like arms as well. I see that quite often when patients complain of that. But
what do you mean extrafacial melasma?
So not necessarily on the face, you know, like on the forearms and things, people start to notice pigmentation. But it's really about remembering to, you know, wear your high factor broad spectrum sun cream, and don't just rely on sun cream, you know. And people always, you know, no matter how wonderful your sun cream is, if you're sitting in direct sunlight, you're not wearing a hat, you know, you're there between 11 and 3, you're going to have problems. So don't expect to rely entirely on your sun cream. Make sure shade, care, you know, sit in the shade, and put your back to the sun. We all say dermatologists have very brown backs.
I mean, I think it's such a good advice, and people sometimes think the SPF will do everything I need it to do, but that, you know, I know now, I mean, I went in like a piece of bacon on tin foil, you know, I was terrible, Justine, but I know now that when I...
Surely not.
Yeah, surely, yes. But when I am in direct sun, I literally feel inflammation out the sun. You know, it's my kind of go-to. Inflammation, what's inflammation lead to? It leads to everything activating in the wrong way. And it kind of, so if you just heat on your face, shouldn't have heat on your face. And then that's my way of remembering, you know, if I'm sort of things.
Sure, I certainly won't,
questions, Faith?
Okay, could we talk a bit about the link between rosacea and pigmentation?
Yes, okay, let's talk about that, because what if you have both? Because then you're like really having a tough time here.
Yes.
But what is the link?
Okay, so actually, interestingly, in my clinic, I tend to see rosacea. I don't see too many people who present with both, because people with rosacea, on the whole, tend to have what we call type 1, type 2 skin. Not all skin types. All skin types can have rosacea, so don't be fooled. Yeah. But it tends to be that sort of more Celtic, I think, in Ireland. I think like 40% of people have some element of rosacea or sensitive skin. So it does tend to be some of the lighter skin tone. But interestingly, there seems to be now some evidence about inflammation and also possible blood vessels being a trigger for melasma. So that may be the link. And obviously, rosacea, it's all about the skin barrier. We know that in rosacea, very often there's a dysfunction of skin barriers. You know, there is. And there's also, you know, skin barrier dysfunction may well have a role in melasma. So that will be the link for me. You know, people underestimate the triggers of light in rosacea. So absolutely wear your high factor broad spectrum sun cream, because it's going to really help your rosacea, but again may well help, you know, obviously with your melasma. So
interesting on when you talk about the type skincare, because there is a grading in dermatology, and we use it here too, of just the different type of skin. So in the Fitzpatrick scale, if you look at type 1 to 7, can you tell me the general things people will most have a concern about in each category?
Right.
Yeah, I just think it's really interesting, because so type 1 and 2 are up to, I would say, peaches and cream.
Yes.
Yeah.
So
this is alabaster,
really
peaches and cream.
Broad brush.
I know, but it's interesting just because I think
this is just my anecdotal.
It's not something talked about much, and I think
agree.
it's interesting for people to understand.
Anecdotal, my experience in clinic, but so type 1, type 2 tends to be one of the problems I see more commonly are things like inflammatory, sort of rosacea, that sort of thing. Obviously, they're more like to sunburn, so I'm very cautious about checking their skin. When I check all my patients' skin from head to toe, that's a given. But we know that type of skin, least protection, so like red hair, blue eyes, fair skin, and so super concerned about sunburn and obviously sort of skin cancer. We're very, very careful in that skin type. Although interestingly, I feel, again, this is completely anecdotal, but people with that skin type tend to age better, and I'm convinced that it's because they are always avoiding the sun. So it's very interesting. When I see them back in my clinic, I always say to them in their 60s, actually, you know,
now it's really working for you.
Well,
even though you were the one staying out of the sun. Lila has a friend who's her hair is so red, 2 sisters, and they literally never go in the sun, and her skin is just, I mean, she's young, but that perfection, and you then see sun damage so easily. So type 3 and 4 are what? Is that sort of getting towards olivey skin?
Yes, more of an olivey skin, etc. And that, that's someone like my husband who has that type 3/4 skin and feels that sun cream just isn't an issue, So
feels he can go and have a little burn.
Yeah,
I mean, because he doesn't burn so much.
He doesn't burn so much, but I think also I noticed with him because he's got that more pigmented skin. I don't think he notices it as much, but I've got my hands on him. I can feel he's hot on his shoulders. So I think again, sometimes you just don't notice it, because you have slightly dark skin tone. But in that group, often it's pigmentary issues, but also, dare I say, photo damage because they've tended not to necessarily wear as much sun cream, and so they come to me with their dyspigmentation, the sunspots, lack of collagen. They want that treatment, etc. And then, of course, those with the sort of even darker skin tone.
So we go 3, 4. So 4. So 4 is more getting towards the caramel skin tone.
Yeah, that's right. So that's the skin tone again. Often it's dyspigmentation.
So when you say that, just for thing, it's when it's a sort of, it just feels the whole thing is a darker patch.
Yes.
Is that what you mean?
So yes. So the skin's become uneven, and so they don't like the fact the skin's become uneven. They want me to treat that uneven skin, and also more likely to have things like melasma. So treating things like melasma, sort of sunspots. So yes, again. That skin type absolutely needs to be wearing a high factor broad spectrum sun cream, and then as you go on again
so then
to darker
6
skin
is
tone.
more toffee and around those kind of skin tones, and then you're going to see again more block.
Yeah, so just more pigmentation issues. So I think in the darker skin tone, it tends to be dyspigmentation, uneven skin tone, which is seen as more the problem with photo aging. And then someone like myself, I'm going to get fine lines. I'm going to, get more. I'm probably going to have more of a problem with that. But I've also got pigmentary. I have to be careful about pigmentation too. Yeah. But probably for my skin type, it's going to be more about, sort of collagen and sort of, the whole thing.
In the deeper skin tone, because we look at undertone as well for makeup, but if you are sitting between 6 and 7 and you have a redder undertone, as opposed to what somebody in that skin tone might refer to as sort of greyish undertone, when they feel in, so a redder undertone skin is more consistent all year round, whereas the greyer undertone feels really pale in the winter. Okay, so which one is susceptible more to sun?
I think, I think we overestimate the protection you get from melanin. It's not enormous, So I think that we think that melanin in a sort of type 6, 7 skin is, you're totally protected from the sun. You're actually not. I can't remember what SPF it gives you. It's about 10. I don't know. Someone can look it up, but it's not a huge SPF. So there's still going to be UV damage. They're going to be less risk at skin cancer, absolutely, but they do get skin cancers. And I do see rosacea, for example, in patients with type 4 skin. And I think that type 4/5 skin, you have to be very careful as a dermatologist, because that's one that tends to suddenly react to a laser. So you have to be super careful that you don't cause post-inflammatory pigmentation in someone in that group. Yeah, you have to be super cautious.
And I think that there are, if you go in clinic to have treatment for melasma, some lasers only pick up on certain skin types, so you've got to make sure you have the right laser.
Oh, absolutely, yeah. So, for example, I wouldn't necessarily use, say, Intense Pots Light for melasma. I think it can make it worse. And I would tend to use, I think the FDA say fractional laser is probably the one that they said for melasma. But I would just say that in all situations, all treatments, chemical peels, laser, etc., you've got to be careful about not causing further post-inflammatory hyperpigmentation. So any good practitioner will be suppressing the process before you start treating. You're not going to walk into my office. I'm not going to say, right, I'm going to treat your melasma. I'm going to be sorting it, suppressing it, treating it. You've got to be very careful how you approach it.
You mean doing topicals first?
Absolutely.
Yeah, because I did a CO2 years ago, very abrasive one for acne pitting, and I got pigmentation from it. Yeah,
and that's the other thing. So you need to be very careful. So get into a good habit, wearing the high factor broad spectrum sun cream, but you need to warn that individual that after those treatments, after a chemical peel, after laser, they are greater risk of post-inflammatory pigmentation in all skin types. So they need to be careful avoiding the sun, using really good high factor broad spectrum sun cream, and just being super careful during that period of recovery. And that can go on for a few weeks. So you've got to be super careful.
So another thing as well, I've started to get, sorry, I'm going to show up my leg, is what I call no pigment left pigmentation. Yeah. Is it called reverse pigmentation?
Yes, or guttate hypomelanosis, we'll call it.
So it's when you get white spots, if you have my colourish skin. I think this appears on every colour skin.
Yes, it does.
But what is that because I've been in the sun so much there's no protection left?
So broadly,
what can I do about it?
Yeah. Broadly, so when our melanocytes, they, throughout their lives, our melanocytes work, they produce melanin, etc. But they start to get a bit tired almost, and so they can overfar, so you get these sunspots, or underfar, and so you're not producing the melanin. Yeah. And it's really to do what we call it field change, and it really means that you've got this sort of sun damage from the sun, and so it isn't the easiest thing to treat. There's no real consensus in the dermatology world about a successful treatment. I've seen some case reports of people doing things like needling in a sun damage treatment. It's what we call 5FU. Needling it in. So
like masotherapy.
Yeah. So putting a needle in and putting 5FU in. I've never done it. I have no idea.
What is 5FU?
It is a topical chemotherapy treatment that we use for sun damage. So I'm very keen on treating what we call field change, and I'm sure in Australia there's lots of field change treatment. And what that is when we've had too much sun, we start to notice changes. So we might get little warty red areas, we might get dyspigmentation, and this is what we call field change. And there is a risk when you've got this damage to the cells that you may develop skin cancers, for example, things like a squamous cell carcinoma. So my view is, particularly if you've had a squamous cell carcinoma, you've got to treat the field to try and reduce the risk, and there are different ways of doing that. So things like 5FU or FUDIX is a common treatment. You do it for about 4 weeks. Your skin will light up, it'll get quite red and sore, but at the end of it, not only have you treated the field and reduced your risk of skin cancer, particularly squamous cell carcinoma, but you've also regenerated the skin a bit too, so you have a nice cosmetic benefit. There are other things we do called daylight PDT.
I'm sorry, that is a chemo drug.
It's a topical yeah, so it can be given systemically for certain cancers, but it's a topical treatment. So it insinuates itself into the cell cycle, and sun-damaged cells or what we call dysplastic cells, they turn over very quickly, so it targets the cells which are turning over, which are damaged basically. And it's the same premise, what we call daylight PDT, where we put a gel on. This is absorbed preferentially by sun-damaged cells. You go into the light, and that combination then causes the cells to be damaged and to die, which are sun-damaged. So these are treatments called field change. So probably it might be worth considering something like treating the field for you, but the bad news is I suspect we won't have much success. Really? I don't think it's that easy to treat, but what you've got to do is prevent further damage.
I'm much more interested in the fact this is an indication my skin has a propensity that I should be careful. It's like, is it your body telling you, hey now, just don't go in the sun anymore, because you don't really have any protection?
Well, yeah, I guess I don't know if there's any evidence necessarily that lighter area, I don't know actually, but what it does mean is you've damaged your skin. You've had enough UV to cause some skin damage. I mean, I would look for other signs in your legs. So, for example, little warty areas, little red areas, which might cause me more concern. But yeah, I mean, it's just a sign that you've had UV. Really, that's what it is. Good old guttate hypomelanosis. So.
Good old guttate hypomelanosis.
Sorry for the bad news.
Thank you. That's great. No, I sort of felt there was nothing to be done, and I remember my mother had it, and she died at 90, and I remember always seeing it. Scottish blood. Faith.
I've seen an interesting comment that I just want to touch on. Cheryl said, I have those white spots on my right arm from driving. Yeah. So the sun coming in from the window, even that.
Yes, so UVA will come through a window, and there's a really famous image which I'm sure many of you may have seen, and it's a truck driver in the States and who has had UVA coming through the window. On this side, it's almost just unrecognisable, the right side from the left. And I see it as a dermatologist. So in clinic, when I get patients undressed to examine their skin, you could almost draw a line from where the UV's come in and where the skin's been protected. It's completely different skin. It has a lovely even pigmentation. It is bouncy, the good collagen, etc. So we know, and coming through windows is absolutely true. Yeah.
I'd say that's on my bottom from how much I went to the sun till I was 30. I mean, I just am, now fanatical, but there's a lot of damage that I know, and post-menopause it does come up. And during menopause, for me, it did come up, and I went to menopause quite early at sort of 45, 48. Yes. So I did notice that change most then, whereas now, because I do so many creams and treatments every single day, I feel it hasn't weirdly progressed since that age till now.
No, and there were really good studies. There were studies which show that if you just use a high factor broad spectrum sun cream every day for a year, people's skin improves. You know, so even just wearing, so it's never too late. That's what I always say to my patients, it's never too late. Never too late.
I was on an aircraft for 22 years. Can you imagine the UV through the windows? Wow, that is, yeah. I can so imagine that, because you think you're high up in the sky, so much UV up there. I had white spots, but over the years, they've blended in with my tan. What's that telling us, darling? I colour the ones, things. But I just, yeah, that is something to think about when you're getting these white spots, to realise, I'm just going to say from your perspective, Justine, is really be aware when that protection's gone down. And I do see it like that. I do see it, to just get yourself checked. So if you're still going in the sun and you've got those white spots, you must be in your 40s or 50s. So do check. There's nothing untoward on the skin.
But actually, make a good point as well. So, for example, if you've got a mixture of lighter spots and darker areas, if you treat the field, you know, or treat the background, you know, even if you do chemical peel and remove some of this, the overpigmentation, or, you know, the hyperpigmentation, then it will blend the lighter areas too. So you'll get a slightly more even-looking skin tone. And what's interesting, it is that homogeneous skin tone that we associate with youth. So that's one of the main things that we notice. You know, at a sort of atavistic level, we look at someone that snap second, we notice their skin tone, and that tells us, it gives a gauge of age. So.
Yeah, it does. Louis, I notice hypomelanosis on my left arm, window side in the States. Exactly. Mina, I have sun damage on my forehead. What can I treat it with? I would say that I mean, very good to watch back on this film if you just joined us, but we talk about, you know, tranexamic acid, vitamin C, retinoids, AHAs as a kind of at-home treatments, and there's lots on the market. We do them too. Mid thing I would say is in clinic. Perhaps stronger hydroquinone on prescription, or azelaic acid combined with other things, and a retinoid.
Yes, absolutely.
You know, a retinoic acid, and then long term, I'd say the laser. If I'm using that categorization.
So then you might want to have an in-clinic treatment. It depends what the sun damage is. So if the sun damage, for example, is like red scaling and sort of actual sort of, you know, what we call field change, then actually having a medical treatment, for example, like FEDIX or daylight PDT.
Now, vitiligo. I always mispronounce it. Vitiligo?
Yes, vitiligo.
Okay, so for those who don't know vitiligo, this lady is also saying, years ago I was told that there was a treatment, but they never bothered as I was pale. Now they're noticeable around only one eye. Any advice? So what can you do if you have it? And first of all, what is vitiligo to the audience?
Yeah, so vitiligo is when you get antibodies. It's an autoimmune disease. You get antibodies against the sort of the pigment-producing cells, and so if you can suppress that process, so
which means you get white patches on your skin. Yeah.
So it's an immune process. So if you can do a topical autoimmune sort of thing to suppress that immune process, that works. So it can work. So, you know, traditionally we've used things like steroids, and we've used things like non-steroid treatments, like Protopic. So the key probably is to get in quite early, and to try and treat it early. But it's not always treatable. You know, and sometimes when the pigmentation comes back, it's not that even. We get what we call perifollicular pigmentation. But it's about making the diagnosis, and sometimes it's not the diagnosis. So, for example, if you've got a very subtle inflammation and you've got a darker skin tone, you can get what we call pityriasis alba, where you start to get sort of post-inflammatory hyperpigmentation. We often see it in children, and it can be misdiagnosed as vitiligo. So someone needs to make sure it is an absence of sort of a pigment as opposed to a suppression of pigment.
She feels she's had it for years. You said treat it early. What can she do?
Well, no, I mean, see your clinician basically, and they may well try some treatment and see if it can help. And I've certainly had patients who've had a long-standing treatment, and it seemed to have worked. Okay. But I think getting the diagnosis is key.
Okay, brilliant. Good advice. Can you recommend the best treatment for my son's acne? Well, Justine's here. Acne, give me your 2 seconds on the best thing, because you like to start with topicals.
I like to
go
start
straight
topicals.
to
I like a top combination of a benzoyl peroxide with a retinoid. And also on subject of pigmentation, if your son's got a darker skin tone, then it's very important right from the get-go to make sure you're calming, hydrating the skin, and using things like niacinamide, which will suppress that pigmentation process. Things like azelaic acid. I love azelaic acid, but I'm very keen on topicals. I think we can do a lot more with topicals in acne than we realize.
Than having to go to Ractone, which I think, there's a lot of people, I was on it But in my daughter's year, I mentioned it to her once, twice when I felt her skin was really playing up, and then you said to her, get on this regime, and she's now much better, and also uses, you know, acid and antibacterial.
Sure.
But I do think some people are nervous because there are some depression things, especially with boys, a bit more than with girls.
Totally understand, has to be handled really carefully, and if there's a risk of scarring or it's severe, of course, then we'll consider all treatments, including systemics, for sure.
When I use self-tanner now, my arms and legs look spotted. It's like all my past skin damage collects at the tanner much more, and I look like a spotted dog. Pam. Okay, I don't know what to say to that.
Well, Pam, it might be that there's a change in the skin barrier. So, for example, there are things that we touched on earlier, seborrheic keratosis, which are very subtle sort of areas of dry little spots on the skin, and they can gather fake tan. So, really moisturise the skin, exfoliate the skin, and moisturise the skin to try and reduce that sort of grip. You know, and then really use the moisturiser first, and then use the tan. And it might be a bit more even. Yeah. So you don't want to get absorbed by the dry bits.
To use, maybe, because I think. Well, I just see lots of people who they just keep piling on a moisturiser, but if they used a bit of an acid, it might actually get the dead skin cells off, and then the moisturiser goes in.
I agree. A little bit of both, balance both. A bit of exfoliation, absolutely. Remove the dead skin cells, and then get your lovely hydration. Absolutely agree. A bit of both.
Yeah. Keel, not sure if you answered this already. How to treat brand new scars less than a month old from spots so it doesn't get worse? This is a great one, and actually I'd love to throw this in because we always get so many questions about how can you treat a scar.
Yes, absolutely. So the good news is quite often in acne people have what we call post-inflammatory erythema, or that's pinkness, or post-inflammatory pigmentation, and they mistake it for a scar. So most of the time we come to my clinic for scarring and acne, actually it's not a scar, so that's good news. But if you get pigmentation after active, you know, inflammatory acne, then that can last for quite a long time. So from the get-go, you need to be using really good high-fat broad-spectrum sun cream, and look for ingredients like azelaic acid and niacinamide, which can remove and help with those blemishes and that pigmentation.
What about if you do have a scar? What about if you've been, you know, had an operation and they first scar? What do you do with a scar?
Okay, so the evidence in scarring and post-operation is probably using things like silica gels. So that's probably got the most evidence for helping a scar. Scars will get better. They always improve with time. And I say to patients, give it at least a year. Massage the scar, keep it hydrated, really massage the scar, and protect from UV, because you don't want to get pigmentation in the scar. But be reassured that most of the time scars will soften, they will lose that redness, they'll become much sort of less red over time. So absolutely overwhelmingly, they will improve. If they're getting itchy or more raised, then seek advice from the physician, because they may need to use something like an anti-inflammatory to stop that overactive scar.
I'm going to ask you something now, which is not for many people, but I had a friend of mine call me the other day whose daughter had done a lot of cutting.
Yes.
And she'd stopped cutting.
Good.
But she was now going out and going to parties and was very overconscious of the scarring from cutting.
Yes.
What would you advise for that?
Yes.
Because they can be quite, some can be,
So again, you know, it may well be what we call post-inflammatory redness or even pigmentation. So again, the same argument, making sure that you're using nice anti-inflammatory treatments, things like silica gel, make sure you're protecting the area from light. And then you can look at treatments, for example, to try and remove that scar and replace it with new collagen. So you know,
can you do laser treatment on scars like that?
Well, I've had some success treating with things like my nanofractional laser, which I think you have nanofractional, and that's been useful. Even things like microneedling can help with scarring, because you're just trying to create new collagen. But I think in the meantime, for confidence, using concealing treatments. So I absolutely love Vichy Derma Blend. It's really, really good. It's a really good concealing makeup, and you can swim in it. You can sort of, you know, and it will stay in place. It matches the skin tone exactly, just to conceal that area till the confidence comes back. Wearing a high-fat sun cream, using silica gel acutely to try and reduce that inflammation.
You get that just in the pharmacy? You
for the things. Kelacote, Dermatix. There are other sticks as well. So silica gel's good. Good old bio oil. You know, bio oil. It's very accessible. It's got lovely anti-inflammatories in it. Massage it in. You know, etc. But I think anything to do to conceal it to help the confidence swell will be really helpful.
That's very good. Very good advice. Okay, we'll take 2 more questions.
I have one. Is there any supplements like collagen that can help with hyperpigmentation?
Okay. You talked about
tranexamic acid. Yeah,
so you can take as a supplement.
Yes, you can take that. That can be prescribed for you. So that's one treatment that you can take orally. But also antioxidants. So your anthocyanins, your vitamin C's. Because obviously it's about those longer wavelengths and trying to sort of mitigate against that free radical damage. So I know there are certainly supplements, which are coming out now as systemic protection, lutein, green tea, and I know,
glutathione.
Glutathione, I know
camu.
Yeah, don't know about that one.
Camu is a very, very strong form of vitamin C. It's stronger than taking a vitamin C supplement.
Right,
and you take it in a powder.
Right.
Yeah. Anyway, I'm just researching these things as I go. We'll be coming back to you soon. And a last question, almost 16 hours, says Elkie, I try to see all my different spots as one for every wonderful day in my life. I have many. Can I just say, what a good comment to end on. You can do nothing and embrace every element of your skin, which is fabulous. If you have anything though that looks at all unusual, as Dr. Justine mentioned at the beginning, please go and see a dermatologist.
Absolutely. So the A, B, C, D, E, asymmetry, the change in border from smooth to raggedy, C, the colours changing, D, if it's getting bigger, E, if it's evolving, is it changing, etc. And the other sign I always like to say is the ugly duckling sign. If everything else on you is like a pale brown, then there's a black lesion or it just stands out. Our moles tend to have a theme. You need to get that checked out.
Great. Very nice advice. As always, such a pleasure. You are a fountain of knowledge, and
such a pleasure to be invited.
I think we learnt so much. Faith always sits here absorbing it too, and she's like, okay, I'm learning about this today. So please leave your comments below. Until next time, bye-bye.